Case 1, it is a very inflammatory, hypercellular lesion, inflammatory, and you can see nice vacuoles. And these vacuoles are rimmed by neutrophils. This is a very, very specific finding. And there are a lot of multinucleated giant cells with epithelioid cells. So it is a granulomatous. And when you do gram stain, this is more like theory. Nobody does gram stain to diagnose this condition. You can identify gram-positive organisms, which are like Corynebacterium. And this is a cystic neutrophilic granulomatous mastitis. So the lipid-like vacuole surrounded by or palisaded by neutrophils with non-necrotizing granulomas are diagnostic of CNGM. And what are all the other inflammatory conditions you should know? Acute mastitis, both puerperal and non-puerperal, but most of the time acute mastitis is diagnosed clinically and we won't get any material from the clinicians. Idiopathic granulomatous mastitis, ductectasia, smold or squamous metaplasia of lactiferous ducts, fat necrosis, lymphocytic mastitis, IgG4 disease, and Rosai-Dorfman disease. These are all the inflammatory diseases you should know. Number 1 for the correct diagnosis, and number 2, these are all the things that they can keep it in the exam. Most of the cases I selected that will be kept in the exam so that you can clear the exam without much trouble. So this is a lobulocentric inflammation, and the high power shows a lot of multinucleated giant cells and epithelioid histiocytes, and these things you have to do AFB and PASD and find out is there any foreign body by polarizing the microscope or lowering the condenser, and you have to rule out the other causes before calling it as idiopathic granulomatous mastitis. In this picture, the ducts are very much dilated and filled with histiocytes, and chronic inflammatory cells and plasma cells are seen around the ducts. And in later stages, the whole duct will be sclerotic and there will be recanalization, like a recanalization of the thrombus. So this is a condition known as duct ectasia. Here you can see the normal nipple, and it's lined by the lactiferous ducts are lined by cuboidal to columnar cells. Whereas in this lesion, these cuboidal cells are replaced by keratinizing squamous cells, causing obstruction that causes accumulation of material leading to abscess formation. And whenever there is an abscess, they will find a way to come out by forming a fistula. And the presence of squamous metaplasia in the lining epithelium is a diagnostic of this condition known as squamous metaplasia of lactiferous ducts. Previously, it is called as subareolar abscess, and it's very common in smokers. And here you can see the normal lining epithelium of the lactiferous ducts replaced by squamous metaplastic epithelium with keratin. So this is very characteristic of subareolar abscess or squamous metaplasia of the lactiferous ducts. And cytology, they may give a sample from this, and you can get a lot of neutrophils with keratinocytes. Okay, when you see squamous cells, nucleated and anucleated with the keratin flakes and neutrophils in a cytology, we have to diagnose smold. This you all should be knowing. This is a lot of adipocytes you can see. See, the beauty is normal adipocytes are not seen because the lipid is lost in the processing. Whereas whenever there is a necrosis, that cytoplasm is preserved and they look like histiocytes. So these are all the necrotic adipocytes, and sometimes they can produce a lot of giant cell reaction with the fibrosis. So this is nothing but fat necrosis. This is very, very important because clinically and radiologically, it may look like a malignant, whereas pathologically, we give the good news of benign condition. Here you can see a lot of lymphocytes in the lobules. And in this picture, again, lymphocytes in the lobules with a dense keloid-like stroma. Sorry. Oops, sorry. Keloid-like stroma, and in the stroma you see the atypical fibroblast. So the intralobular lymphocytes with the keloid-like collagen and the atypical fibroblast is very diagnostic of diabetic mastopathy, which is a member of a lymphocytic mastitis. Any autoimmune disease, remember diabetes is an autoimmune disease, and any autoimmune disease can produce these changes. And here you can see a lot of lymphoplasmacytic infiltrate and a lot of lamellar sclerosis. And this is a immunohistochemical stain for IgG4. And this is very classic of IgG4 disease. The criteria for IgG4 is lymphoplasmacytic infiltrate, lamellar fibrosis, and periphlebitis. In breast, periphlebitis won't be seen that much. But when you do immunohistochemistry for IgG4, it will be more than 40%. And this you all have to remember whenever you see a lot of lymphoplasmacytic infiltrate in any organ. Here it is around the breast and in the stroma. And these lymphocytes are engulfed by the macrophages, which is emperipolysis. So this is diagnostic of Rosai-Dorfman disease. And whenever you see, there's a practical point, whenever you see lymphocytic mastitis, you have to think of BRCA-associated tumor, or what we used to call medullary carcinoma, now medullary pattern of infiltrating breast carcinoma. So it will have pushing margin, intratumoral lymphocytes, central necrosis, and it will be triple negative. So whenever you see lymphocytic mastitis in a mass lesion, they might have missed the biopsy of a BRCA1 associated tumor. The second lesion, it's again very hypercellular lesion. It's very well circumscribed, and these are all made up of glands. So this is a epithelial lesion. And when you go to high power, this is having a very hobnail pattern where the nuclei are trying to come out, and the cytoplasm shows a lot of vacuoles. So it looks like microvesicular steatosis in the liver. I love to compare the changes happening in one organ to other organ so that you can diagnose conditions very easily. So this is a hobnail cells with microvesicular cytoplasmic vacuoles, and in the previous picture, low power, we saw the tubules, and this is nothing but secretion trying to form a somoma body like somomatoid concretions. So this is diagnostic of lactating adenoma. And this is another slide, well circumscribed lesion. You can see the normal tissue, well circumscribed lesion, again glands. Here the glands are not having the hobnail pattern, and here you can see the myoepithelial cells also. So these are all the tubular glands forming a lesion. So this is known as tubular adenoma. Going to case number 3, very cellular, and a lot of inflammation is also happening. And whenever there's a lot of lymphocytes, you have to be careful and take recuts or resampling, because lymphocytes are our policeman, and they may be able to identify carcinoma either when there is invasion or InSitu level itself. Okay, so when lymphocyte rich areas, be careful, look for malignancy, go for deepers or resampling. Here you can see pink cells with some nuclear atypia. But in the low power, if you see, it is arranged in a lobular pattern. That lobularity is maintained. That is very important. And when you do P63, most of the cells are having the myoepithelial cells. That is also highlighted by the cytokeratin 5-6. But see, these are all the normal glands, whereas here there is some epithelial proliferation. So some epithelial proliferation is happening, and some background benign ducts are also there, but the lobular pattern is preserved. That gives the diagnosis of sclerosing adenosis, and these epithelial cells are nothing but ductal carcinoma in situ. So this is a DCIS involving the sclerosing adenosis, and that brings the heading of sclerosing lesions. There are 4 sclerosing lesions you have to remember in breast. You have to classify them into benign and malignant. Sclerosing adenosis, radial scar or complex sclerosing lesion, and microglandular adenosis are the benign sclerosing lesions, and tubular carcinoma is the malignant sclerosing lesion. And the complex sclerosing lesion is a new terminology. Whenever the lesion is more than 1 centimeter, we call it CSL. When the lesion is less than 1 centimeter, we call it as a radial scar. This is a picture of sclerosing adenosis where the lobularity is maintained. Here it is like lobularity is not maintained, okay? But you can see the central scar and epithelial proliferation. But the main clue is the cysts or the ducts, they get dilated as they are traveling or as they are present in the periphery. Peripheral ductular dilatation is very, very important for the diagnosis of radial scar. Microglandular adenosis, it's adenosis, increased number of gland-like structures. And this is the only benign condition where you don't have myoepithelial cell. Remember, I told you benign conditions have myoepithelial cells, but this is the only condition. And another clue is the colloid-like secretions in the center. And tubular carcinoma, again, these are arranged in glands, and see the difference between the carcinomatous gland and a benign gland. Benign gland are round, despite the organ, in any organ. If you see the round glands, it's a benign. But when you see angulated glands, branched glands, irregular glands, it is malignant. So again, sclerosing adenosis, complex radial sclerosing lesion, microglandular adenosis, and tubular carcinoma. This table tells you what I already talked about. Okay. So this is the high power view. Sclerosing adenosis is the most common benign condition associated with microcalcifications. The complex radial scar, the central area will show a lot of elastosis. The microglandular adenosis, as I told you, it will have a lot of colloid-like secretions, no myoepithelial cells. Angulated glands with apical snouts. Can you see all snouts? This is the classic of tubular carcinoma. P63 will be maintained in sclerosing adenosis and in complex sclerosing lesion, whereas P63 will be absent in microglandular adenosis, and S100 will be very strongly positive in microglandular adenosis. Again, P63 absent in the tubular carcinoma, whereas it is present in the background benign tissue. And the microglandular adenosis, now they are speculating a spectrum that leads to atypical microglandular adenosis and that leads to triple negative carcinoma. And they think the acinar cell carcinoma and metaplastic carcinoma are arising from microglandular adenosis. That's why you have to remember that. And this table tells you the difference, but the main difference is the cytological atypia and glandular shape. So now we are coming to case number 4, where there is epithelial proliferation, microcalcifications. And these epithelial proliferation are having punched out spaces which are nothing but cribriform pattern. So this is a low-grade DCIS with papillary and cribriform carcinomas. You can see some papillary patterns here. And DCIS is nothing but monomorphic proliferation of epithelial cells. There is no myoepithelial cell proliferation. The myoepithelial cells are in the periphery, and the epithelial proliferation is predominantly occupying the lesion. And the nuclei are divided into 3 grades, grade 1, grade 2, grade 3. And this is not very, very practically possible to differentiate. If you see the table, these are very good for the exam. Grade 1 is having some features, grade 3 is having some features. There is an intermediate in the grade 2. So we cannot correctly diagnose. That's why they are going for two-tier system where there is low grade and high grade. And in the high grade, we have to classify whether necrosis is present or not. So these are all the 3-grade system. This is grade 1, where there is uniformity of the nuclei. Grade 3, variation in size and shape of the nuclei with irregular nuclear membrane, and grade 2 is intermediate between grade 1 and 3. What are the types of DCIS? Depending upon the architecture, morphology, and nuclear grade, we have different types. And for example, in the architecture, it can be cribriform, papillary, micropapillary. In the morphology, it can be apocrine, clear cell, spindle cell, small cell, like that. And this typing of DCIS is very, very important for the exam. So the DCIS have two differential diagnoses. One is ductal epithelial hyperplasia. Other one is breast lesions having cribriform pattern. And what do you mean by duct epithelial hyperplasia? Remember, I told you normally the acini and the ducts will have only two layers of cells, luminal epithelial cell and abluminal myoepithelial cell. If you see more than two layers of cells, heterogeneous cells, remember ductal, lobular, or myoepithelial cell, then it is ductal epithelial hyperplasia. And they are divided into mild, moderate, and severe depending upon the number of cells and formation of the bridges. When you call mild, when it is up to 4 cells. In moderate, these proliferating cells form bridging, whereas in severe, there is obliteration of the lumen by the hyperplastic cells. So these are all the examples of mild, where more than 2 layers of cells, but up to 4 layers. And here they proliferate and they form bridges. And here they are completely occlude the luminal space with peripheral slit-like spaces. So how will you differentiate ductal epithelial hyperplasia? In the low power, the ductal epithelial hyperplasia, the spaces will be irregular and irregular in size, shape, and distribution. Whereas here, the spaces in cribriform carcinoma, they will be regular and uniform size, shape, distribution. And more importantly, the cells will be overlapping in hyperplasia, whereas in DCIS, they will be moving away from each other. This is a very, very important thing you have to remember. In all other organs, overlapping the nuclei is malignant, whereas in breast, the overlapping of the nuclei is benign. And in the high power, you can see here the cells are more overlapping, and you can see heterogeneous population, epithelial cell and myoepithelial cell. Whereas here the cells are not overlapping and it's predominantly or only epithelial cell proliferation. See, these are all examples of florid DEH. You can see the epithelial cell and myoepithelial cell and overlapping of the nuclei. Very, very important for ductal epithelial hyperplasia. And immunohistochemistry is very, very useful. In P63, when you do the DCIS, all the myoepithelial cells will be only in the periphery. Whereas the myoepithelial cells here highlighted by SMA, you can see in the center of the lesion also. And as I told you before, estrogen receptor heterogeneously positive in DEH and homogeneously positive in DCIS. The next problem with cribriform DCIS is the other cribriform lesions of the breast. And then again, you have to classify them into benign, malignant, which is InSitu and invasive. Collagenous spiralosis is very, very good example of cribriform benign lesion, whereas cribriform DCIS we already saw. And there are two tumors that can have cribriform pattern in the breast. They are invasive cribriform carcinoma and adenoid cystic carcinoma. This is the example of collagenous spiralosis. This is the low power example of DCIS. This is the cribriform carcinoma, and this is the adenoid cystic. See how they resemble each other in the low power. And when you go to high power, the collagenous spiralosis will have epithelial and myoepithelial cells, and center will have hyalinized material. Again, the lumens will be irregular in size, shape, distribution. Whereas in DCIS, you never see myoepithelial cells, and the cell nuclei are not overlapping, and the spaces of uniform size, shape, distribution. And when you do a marker, myoepithelial marker, they will be positive only in the periphery in case of DCIS. This is a smooth muscle myosin heavy chain, and that's why it is taking cytoplasm all around the proliferation, nothing in the center. Whereas when you do P63 in the collagenous spirulosis, you can see in the center as well as in the periphery. This is an invasive cribriform carcinoma. Here, the myoepithelial cells are absent, whereas in DCIS, the myoepithelial cells should be present. And adenoid cystic carcinoma, you all know we have a specific marker, MOIB, nuclear marker will be positive. When do you diagnose atypical ductal hyperplasia? The main you have to tell is ADH is DCIS up to 2 ducts. For example, here they look like DCIS, classic DCIS, okay, in the high power. But when you go to the slide, that area is less than 2 millimeter, okay. When it is less than 2 millimeter or up to 2 ducts, then we call ADH. So ADH is a quantitative diagnosis. It is DCIS within 2 ducts or less than 2 millimeter.